on surgery versus thermal ablation for small size liver metastasis from colorectal. This is a collision trial, which is a phase 3 randomized trial, and this is what I would be describing about. So it is a colorectal liver metastasis surgery versus thermal ablation, and this is the phase 3 randomized control trial, collision trials. So as everybody knows, according to NCCN guidelines, the liver resection is a treatment of choice for resectable liver cancer. And here the R0 resection is the predominant thing when the hepatic function is adequate, the extent of disease is limited, and that's how R0 resection is achievable with R0 at the surgical site, that is a primary site as well, that is in colorectal. There is no role of debulking surgery, that is where R0 resection is not possible. When the patient is having metastasis and he is not up for surgery or thermal ablation, either complementary like chemotherapy, portalmin embolization, Y90 radioembolization can be considered as one of the treatment option to downstage it and then to offer them a curative resection. And ablative techniques, be it thermal ablation like RFA or a microwave, can be considered either in combination to a surgery resection or as alone for ablative therapy. And this has to be R0 or A0 ablation, as we call it in our language. Arterially directed therapy like Y90 can be considered when they are chemo resistant or chemo refractory. So this is what ASCO tells. Either surgery can be considered along with plus minus ablation or SBRT when there is no other treatment option or in a trial setting. This is what all is about. So when the lesion is in segment 2 of the lesion, liver, the surgery forms the best possible for the resection because it is close to the bowel, it is close to the stomach. Ablation here would not be possible. We have to use adjuvant techniques. It's along with, but surgery is pretty much easy. It's just either subsegmental or a wedge resection is easily possible. When the lesion is located in segment 6 of the lesion, everything is doable, like surgery or ablation, both would be equally good. The liver volume would be also not much. So either surgery or ablation would be the treatment of the choice. When lesion is deep-seated lesion, when the surgical resection would entail more of right hepatectomy, more of normal liver parenchyma is knocked off. So that is the time ablation can be considered either in segment 8 or in segment 4 of the liver. So that is when the ablation forms a predominant thing. And when it is located in the central, close to the porta or the biliary radicals, that is the time either irreversible electroporation, if it is available, or that is one of the non-thermal ablation, as we call. So the cell death is by apoptosis as opposed to coagulative necrosis in RFA and microwave. So either SBRT or IRE would be considered. So here either resect or ablate, as I told. So here would be ablate because you are losing more of a normal liver parenchyma, and in the last IRE, that is non-thermal ablation, that is irreversible electroporation, or SBRT if IRE is not available. So these are some of the group of patients which we consider normally, and this is what about the collision trial when they combine either resection or ablation all together. And this is when they had compared the 10 years data which was available, the accrual for 10 years from surgical resection versus the MCOT trial from the Netherlands. Both showed equal survival and equal benefit, and they had done pretty long, at least 10 years survival in that. Coming on to systemic and meta-analysis, which was published in CVIR, which is one of the intervention radiology journal, where the complication rate of liver ablation is less as compared to hepatic resection, whereas the overall survival is slightly better in the surgical arm as compared to the ablation arm. So coming on to some of, so what does, how does the improved outcome in thermal ablation would be when we have a larger ablation margin. So margins are most important, and it is always margins, margins and margins as we call. So at least 5 millimeters to 1 centimeter of margins need to be available when we are doing any ablative form of therapy. As we know, there is improved guidance. We have fusion technology which is coming in. Either combination of DSA with ablation can be performed simultaneously, or fusion, that is a CT with ultrasound fusion, can be done. And we try to not misregister too much where the lesion is not seen. So that's how we normally do ablation. So either it could be open or percutaneous. Percutaneous is much better because we can do it under CT guidance. We can know the margins as well, which on open would be difficult because it is always under ultrasound guidance where the air bubble forms, and that's what the difficulty is. So coming on to the various surgery and ablation, be it from US, France, or from the UK, so all have the resections and ablations is more or less equal. The survival data is more or less same. So are we open for this randomized trial? So here the surgery is compared with ablation, and this is what the collision trial tells about. So here in surgical arm, the mortality is 1 to 3%, whereas in ablation arm, the mortality is 0.3%. The complication is around 20% in the surgical arm, whereas in ablation arm, it is around less than 5%. The hospital stay is more of less than 24 hours for the ablation, whereas 4 to 7 days in the surgical arm. The cost would be significantly different because the surgical cost plus your admission cost predominantly forms the direct cost, whereas the cost is much lesser in ablation arm. The local site recurrence is approximately 10 to 12% in all of the ablative arm, whereas surgical site recurrence is around 2 to 4%. Re-resection is feasible, re-ablation is also feasible. However, in re-resection, there would be fibrosis, and it would be little difficult. So when we are considering low volume center, resection is always preferred. Where we are having high volume center, ablation is preferred. This is what the majority of the trials showed. So this is again the collision trial, which was done in 2018, and they had also done similar trials. Total number of colorectal liver metastases were less than 10, where one more than one can be resected or ablated, and the lesion should be less than 3 centimeter in size, and additional resection if more than 3 centimeter is allowed. So when they had staged into 3 different categories, where they had limited burden, intermediate burden, and high burden. And intermediate and high, they did intra-op ultrasound and then randomized into either a resection arm or an ablation arm, and then they were followed up. So this is what about resection and ablation in the one arm, and this is what about resection and ablation if there are 10 lesions. So in this trial, they had done if it's not feasible. So stopping rules were if there was high incidence of adverse event, that is CTCE, and more probably non-inferior if it is less than 20%. Whereas the stopping rule for benefit was low adverse event, more local, equal local control, and probability of ablation is more than 90%. So this is how they were randomized, and approximately 148 patients were randomized. Out of 448, rest were discarded after exclusion. And what did they found? Here the KRAS mutation was found in 50%, BRAF was found in 11%, and synchronous and metachronous were almost equal. So 22% had chemo first in most of the patient, and 62% had a low disease burden. So in 64% of the patient had resection which was low burden, and laparoscopic resection was possible, whereas 83% of the patient had ablation which was percutaneous and was performed in this group of patients. So the recurrence rate was around 21 had recurrence in resection arm, whereas 18% had resection in ablation arm. And so overall survival was almost similar. Resection is comparable to ablation in most and this was conditional non-inferior in 91%. Distant progression, that is free survival, local tumor progression, free survival, local control, including repeat treatment and adverse event. These were the secondary endpoint, and these were more or less similar. So the complication was much less in ablation arm, whereas complication was slightly more in resection arm. And these were some of the complications which was done. Length of hospital stay was less in ablation compared to resection, and disease-free, distant progression-free was almost similar. So hazard ratio was around 1.03. And this was not statistically significant. So resection and ablation, a local tumor progression-free was almost similar, which was not statistically significant. Local control was again similar. So these were some of the analysis. So coalition trial was stopped at the half time based on the predefined stop rules. Thus benefiting the experimental arm, that is the ablation arm, over a standard of care resection. So the morbidity was much lesser. So mortality was around 2.1 in resection arm versus 0% in ablation arm. 90-day mortality was around 2.1% versus ablation, which was 0.7. So adverse event was resection. In resection was 56%, whereas in 19% in ablation. So thus it was proved that ablation did not compromise the overall survival. There was no difference in progression-free survival as well. And this is what is all about. Ablation is non-inferior compared to resection. Thank you.
Thank you, Kunal.
Yeah.
We'll have the panel discussion and the questions. Okay. Thank you. May I call upon the next speaker, Dr.